Yes, okay. Good morning, everybody. I'm Ted Popov from Sofia, Bulgaria, and it's sort of an experiment that we are carrying out with Johnny Peter, because it's an unlikely format that we try to adapt to now. We have to squeeze all the information into a very short period of time. My understanding, my reading of that, the instructions that we received from the organizers would be that we have to present something quite recent, something quite hot off the press, so to say. And let me just go ahead now. Just to let you know that the last two questions are a little bit different from what you saw on the slide that was presented by Johnny Peter. So I'll be covering two papers, because I can't really put together all the plethora of hits that come out when you try to enter the keywords for the topic in PubMed. So it will be a paper on the optimal updosing of omalizumab and antihistamines in patients responding to omalizumab that I'll be telling you about. There's this paper that comes from the Netherlands, and it's giving us a retrospective analysis of the patients they had. They had some 166 patients with chronic urticaria that were indicated for treatment with omalizumab, and that was something they retrieved from their database. And out of those 166 patients, 44 patients were continued on higher doses of omalizumab because they didn't get enough effect from the standard treatment of 300 milligrams every 4 weeks. So what they did is, after initial 5 injections that they gave the patients, they selected the ones that had no effect or that had just partial effect, and they put them on 450 and 600 milligrams. And then they carried on for another 3 cycles. And if patients on 600 dose didn't get enough effect, they shortened the period between the applications to 2 weeks from 4 weeks. And then if another 2 cycles didn't work out, then they just discontinued the patient. What happened was that the added value of increasing the dose of omalizumab was evident. It was like 61% improvement in those patients who didn't get enough control with standard doses of omalizumab. You see the urticaria activity score 7 here as a marker of effectiveness. The baseline is on the first bar here that you can see, floating bar. And then you have the baseline for the higher doses, and this is 450, 600. And then you have the result of the treatment with the higher doses. You can see the clear-cut difference between baseline high dose and the end treatment high dose of patients with chronic urticaria. So basically that is another proof that there's a good benefit of higher doses of omalizumab, but we'll have to discuss it maybe more in detail. This is a study from the leader in terms of number of centers. This is Brazil. This is a summary of what of the 6 centers of ViewCare they have there. It's really something that just appeared on the internet. And they tried to see whether antihistamines would be needed if complete control or total control of urticaria has been achieved. And I put the bars of interest into red so as to make things easier for you. So it was a study, again, with 162 patients, which started, oops. Oh, where did I go? I lost it. Why should it happen to me?
Are you pushing that? Push that one to go back.
Okay, so.
Hang on, start. Okay, now push that one. That one there. Push again. And that one.
I can't get to the right slide, but apparently it was for 2 years old long study. And for those 2 years, there were checking points every 6 months. After the first month, we had still patients who were not well controlled here. The 46%, that was first visit 1 month after the first application. And you can see that at that time, all the everybody was practically on antihistamines, and antihistamines were, as you know, we postulate that these are the mainstay of the therapy. Then, after 6 months, some 30 patients dropped out, not dropped out, but were discontinued because they had a complete remission. And you can see that there was a good effect, a complete effect on 74, on 3/4 of the patients that are remaining, 135. And then you can see the incremental trend that lines up here until the last visit on month 24. Where you have, again, only 53 patients remaining in the study. All of them have been on omalizumab, despite the fact that most of them have been without any symptoms. And out of these, already 1/3 don't discontinue any kind of antihistamines. This is telling us that antihistamines might not be needed in many of those patients who obtain a good result at the beginning of the treatment. So one of the questions that we may have to discuss and bear in mind in designing specific studies would be whether we need antihistamines all the time or whether we should just use them on as needed basis. And by the way, this topic has been covered in another paper that actually tells us all. I don't need whether we need conferences like that, Marcus. You put it all in this paper, and on this scheme here, there's this paper is called How to Treat Patients with Chronic Spontaneous Urticaria with Omalizumab, Questions and Answers. And there's a long list of different outcomes that could be discussed and answers to the different questions that might arise. No time for further ado here. But just to point your attention to this paper, which might be a very useful guide for everyone to have it in their pockets so that they could follow up on their patients individually and find out whether everything's the way they want them. And just to emphasize something different, we are talking about updosing, we are talking about accessibility to omalizumab. Marcus was telling us how we want as much as omalizumab or lingelizumab to be available for our patients, but this is unfortunately not the case. It's not readily available in all countries for reimbursement, and in middle and low income countries, reimbursement is essential because otherwise patients cannot afford it. So there's this philosophical, let's call it, paper that is telling us about the importance of angioedema in promoting to the authorities the need to reimburse omalizumab for treatment of urticaria. And there's this schematic here, this cartoon, that's telling us that angioedema is bringing along fear of suffocation and death, dramatic disruption of quality of life, addiction to corticosteroids. All those things present themselves with increased healthcare costs, complications, aggressive treatment. And basically, this is a message that we need to emphasize in our presentations to the public and to the media. And I think that, sorry for the disruption of the presentation at one point, but this is what we have now. And please help us now how to proceed from this point on.
No, thank you. I think we're short of time, so what I thought to do here is we've got this big expert panel here. I think they've been listening to what we said, and I think the question I'll ask is not what you do, but does anybody disagree with some things that have been put up? Does anybody have a different treatment thing or something they think needs to be discussed here from the expert side of things? Or are people happy with what we've shown in the slides? Kieran.
Well, for this slide, the death should not be there. Patients may have fear of suffocation, but death generally with angioedema is less common. I don't think it is true. Well, most important billion-dollar question is when to stop omalizumab. And in India, the patient dictates when to stop omalizumab because he is paying from his own pocket. So I give it for first 3 to 6 months, and then he takes every 3 weeks, 4 weeks, 6 weeks. He said, whenever you start getting hives, come to me, I'll give injection. But obviously others think it is different, and definitely patients at one point of time can be only on omalizumab without antihistamines. That is what millionaire patients, one of few of patients want. I don't take any tablets, just one injection once in 2 months and I'm free. So there are some client of patients, these also. So that is what is my perception of omalizumab treatment, how I decide.
Well, we're just scratching on the surface with those presentations and presenting other work rather than our own work on those things, on those different approaches. I believe that apart from what we mentioned in this questions and answers paper that's been published, we have a good session tomorrow at 9:45 where you could hear from the horse's mouth things from Connie Catillaris and Alan Kaplan, which will be focusing on the little details of approaches and management of chronic urticaria with or without angioedema.
Well, one of my comments, because I agree with most of the points in respect with giving omalizumab to pregnancy. It is safe, probably. We have a big experience with this, and to give omalizumab to children. So my only comment is about stopping or when to stop, but my comment is it possible to stop? Because our experience is, after treating more than 300 patients in Israel, and we published that, is even after 3 years, if you take the patients who responded in almost a full way, they are in remission. These patients who started omalizumab when they have US7 above 36, they were severe patients. In our hands, only 10%, 12% could stop. 85, even more patients could not stop omalizumab. The only thing that could happen to them is just to open the gap a little bit. So our experience is that patients who respond perfectly to omalizumab, but they were severe in the beginning, in our hands, at least after 3 years, in 85% of cases, we cannot stop omalizumab. So we need to enlarge this experience and to collect not 300, but maybe more than 1,000 or more patients to be able to answer this question, can we stop in severe patients omalizumab?
Elias, and you get differences between such people who started omalizumab comparing with the the time of the duration, the previous history of the CSU, because normally we are including patients which are very severe with more than 5 years, or 7 or 10 years refractory to anti-H1, and probably in the future will change. In fact, we are including people who are not so bad. You know.
It's a perfect comment. When in Israel, happily enough, we have the omalizumab license, but it is licensed only for severe patients first, and it's licensed for patients who suffered enough, which means that most of these patients that I'm talking about, they started OMA maybe more than, after 1 or more years, and this is a perfect comment. It's only Marcus in Berlin can start omalizumab after 2 months, but it is Germany, you know, but this is a perfect comment, but this is why we need a large amount of patients to discriminate this point.
Elias, you are very right about this comment that you have about the need for omalizumab for more than 6 months or more than 1 year or more than 3 years, which is something that we need to consider and which has some very important implications from point of view of the healthcare system and the insurers, because we are talking about costs. And as we see that many health insurance funds have some reservations, to put it mildly, to give the patients the opportunity to be treated with omalizumab to start with. So we need to come up with studies, as you say. We need more patients. Maybe we need this UCARE, this history that we are having now to be used for that. But we need to come up with suggestions, with international papers and position statements about the need for that. I totally agree. And let's see what happens with the next generation anti-chronic urticaria biological
it's very important, this, Dr. Popov, because actually what the data that we have from the clinical trials for omalizumab is short-term treatment, and is not the correct approach for CSU patients. Then probably the design for the new anti-IgE therapy will help in this sense to convince the payers that the treatment should be addressed at least during 1 year or many times.
We're getting red things over here. I think we'll have to stop. We'll go to the next set of talks.
Or maybe we need the questions now. You have time?
Oh, we've got time. Oh, okay. They're even getting red signals from over here. Oh, one more comment then. Okay.
Yes, having access to omalizumab even from the first 2 months, I'm a lucky guy like Marcus in Greece. I totally agree that the subgroup with not severe chronic urticaria must be tried to prolong the intervals after a 6-month period up to 8 weeks in order to see if the disease is gone. And I would like to set a query to all of you. In case of reappearance after stopping, there are 2 different strategies. One, to start from the licensed dose of 300 every 4 weeks, and there are supporters of another alternative to start from the last interval that could control the patient. I'm fan of the first option, to start from the licensed dose and then trying again to prolong. I would like to have your comment if you have this experience. I believe that it's a common clinical problem.
Thanks. I agree. I mean, I don't have that much personal experience. I did see a nice letter, I think, Marcus, from your group, with just a strategy of, similar to what you're saying, different options. The one being just to increase by 1 week each time, and then once you've gone without 8 weeks and no return of symptoms, then you can stop for a while. That's one approach. But your points, I just think there's not that much data.
You're opening up quite a new universe. It's a long story that we have to discuss here. Can we afford it now? No,
Yeah.
we don't have time.
We need Chris and Simon to add on this because that's exactly the point of the discussion where we need your input.
Indeed. Excellent.
Okay.
So we're going to do this question, or can we do a question or not, to get the audience involved? Not enough time.
Let's listen to Chris and Simon first and
Excellent.
then take it from there.